I was a trainee in psychiatry when I was luckily exposed to evolutionary thinking by complete coincidence. And then when I started reading about it and learning about it, I thought that's it. That's the missing organizing principle we need to understand psychiatry.
I'm Adam Hunt, and this is the Evolving Psychiatry podcast, rethinking mental health through an evolutionary lens. Share it with the people who matter, like it if you like it, subscribe if you want to hear more. Dr. Annie Swanepoel is a consultant child and adolescent psychiatrist in North East London NHS Foundation Trust and holds a PhD in Human Physiology. She's played a long-standing role in the Evolutionary Psychiatry Special Interest Group of the Royal College of Psychiatrists, serving on the executive committee for many years, including being editor of the newsletter and finance officer. She's published multiple papers on evolution and ADHD, which is obviously one of the conditions she sees the most in her work. And that's what we're going to be talking about today. So, Annie, thank you for coming on the podcast.
Thank you very much for inviting me.
Okay, so I thought it'd be cool if we can just start off with a little bit of a bio, a personal story about how you were kind of exposed to evolutionary ideas about psychiatry in the first place, in particular ADHD maybe, but like where did these come into your life as a clinician, your kind of progress? What do you think before you had evolutionary perspectives and now, how has it kind of affected you? Give me the story.
Well, Adam, as a psychiatrist, we have to study medicine first, general medicine. And for that, my favorite subject was physiology, because physiology tells you about the normal functioning of the body. And if you understand how the normal body functions, it's so much easier to understand pathology. So if you know how the normal heart and lung circulation work, you don't have to learn and memorize what happens in heart failure because you can work it out because you understand the underlying mechanisms. Then I went into psychiatry and all that was missing. So we were learning about symptoms and about pathologies without any underlying organizing principle. Because physiology doesn't work for psychiatry, it works for neurology, but not for psychiatry. And and I found that enormously frustrating. I found that a real gap because for me, I like to know how things work rather than just memorizing what's going on. And I was a trainee in psychiatry when I was luckily exposed to evolutionary thinking by complete coincidence. And then when I started reading about it and learning about it, I thought that's it. That's the missing organizing principle we need to understand psychiatry, to understand what's normal and what's an adaptation to a harsh environment and what is pathology. And all of that is missing in traditional psychiatric teaching for everything. For ADHD in particular, I have a rather funny story because when I trained as a child and adolescent psychiatrist, in the first clinic I attended to assess children for ADHD, we saw a little boy, and so I was the trainee, I was shadowing the consultant then. Saw a little boy who was being assessed for ADHD, and he was all over the place. He was climbing on the chairs and crawling underneath the chairs and just about bouncing off the walls. And then afterwards, the consultant said to me, "So, Annie, what do you think?" And I said, "No, this child is absolutely fine." And she said, "What?" And I said, "Oh, he's just a normal boy." And she said, "No, Annie, he has severe ADHD." And I said, "No, he's just like my brother." And she said, "It's your brother has severe ADHD." That was complete eye opener for me because I was normal. I knew so many boys who were like that, who were boisterous, and I just thought it was what boys are like. But then, of course, in the clinic, I saw how these kids suffer when they are at school and how they may just sit still, which my brother also did, by the way, and how much medication can help. And there was a lot I learned in the ADHD clinic. And then combining that with the evolutionary understanding was revelationary.
I'm really reminded of the term little monkeys. Like we are like just seeing kind of kids just running around and playing on things and just pulling things and that's the thing that obviously we're diagnosing. And yeah, it's an interesting question with ADHD, right? Because I think most evolutionary informed kind of thinkers accept that it's not like a true disorder. It's not like real breakage. There's a mismatch here. You're just kind of, but not fitting into modern life. And as you say, that does mean that you should give treatment to people sometimes. What did you ever try and like mention did you ever say like, oh, but what if this is normal or like our society is weird? Obviously you had this deep interest, but I'm wondering like how much you brought it up, or did you bother to say this to your colleagues, or did you kind of wait and kind of keep it as like an interest that you held and then and waited until you found other people who were interested? I don't know.
Yeah,
Yeah.
it is an interest I held because another really important aspect of evolutionary thinking is the goodness of fit. So I always talk about how when we talk about evolution, people think it's about survival of the fittest, but actually that's not true. It's survival of those who have the best fit between the individual and the environment. You don't have to be particularly clever or strong or fast to survive. And that's why we have slugs and sloths and tortoises, as an example. And this goodness of fit is extremely important in the ADHD clinic, or many other places too, because if you have a child who's really active and has loads of energy and they are, let's say, on a football camp, that is seen as a real strength. But if that same child is in school, where they have one class after the other, where they're expected to sit still and concentrate, it's seen as a weakness. And that is I think, a much better way of thinking about it than saying this child has a pathology. I think we need to really consider the environment they're in.
The little quip I have in my book draft, which I'm working on at the moment, is that human evolution is less about survival of the fittest and more about survival of the fit-ins. So, like fitting in to your social group and your environment along with everyone else. It's not just like about fighting everyone else and like, no, actually you're this community, you're kind of living in a clearing in a jungle and going out and trying to find food all the time and just like fitting into that environment and that society is what humans are meant to be doing. We are like interdependent. We are collaborating. We are working together. So yeah, the survival of the fittest is a bad way to put it. Absolutely. So so then like you've been using these explanations for a while. You've been thinking about them for basically since you were kind of getting into the field. Yeah, what's your experience been of kind of using them? How have they affected you? How do they affect your kind of interactions with patients? And like, do you use them in the clinic ever? Like, what's that like?
It's a complete revelation for me because before I understood the evolutionary perspective of ADHD, I didn't know when to treat a child and when not to treat a child. Because that's really the most important decision a psychiatrist makes is, do I medicate this child or not? And prior to understanding the evolutionary approach, I was always trying to figure out, is this a real ADHD in the sense of it being genetic, biological, or is it something which is perhaps more due to the environment? I was trying to figure out what the origin of the ADHD is in order to decide whether I treat or not. And that is an absolutely thankless task because you can never figure it out. And knowing what I know now, it's impossible because nature and nurture are so intertwined, you are never going to tease them apart. But now, with the evolutionary approach, my question is, does this child fit into the environment? And if not, can we change the environment first? Now, are there strategies which can be used to make the environment more suitable for the child? Usually the steel environment in my work. Or do we need to actually adapt the child biologically by providing medication to make it easier for them to fit into an environment they need in order to progress with their education or with their future plans? And that has provided so much clarity for me that it's now very easy to think, what do I need to do, and when is it ethical to prescribe medication and when not. So it's really a wonderful way of understanding ADHD, the evolutionary perspective. And I'm very glad that more and more people are interested in it, and particularly with it being picked up through the neurodiversity movement as well. But there's more work to do, and that's why I agreed to speak to you on the podcast.
Yeah, damn right. It's very interesting, and it's the one that I think everyone automatically kind of sees. Oh, this is the society. Classrooms are really weird. Workplaces are really weird. You wouldn't really notice that these people have a real problem. I mean, we weren't really diagnosing ADHD before whatever 30, 40 years ago. In a future episode, I'll be interviewing Alan Francis, who introduced the oversaw the DSM-3 and kind of regrets how broad ADHD was at the time and how it's been kind of, in his mind, overdiagnosed. I don't know if you have a perspective on that in terms of like, yeah, should it be the 7% or should it be the 2%? And I mean, the other interesting thing here is that like quite a lot of people who are diagnosed don't actually use medication. Something I think in the UK, it's something like only like 20% actually use the medication. And I know quite a few people who have diagnosis who they try it a bit and they're like, oh, actually, I don't really like the side effects. I'm fine. I'm just going to try. I don't want to be reliant on this drug. Anyway, yeah. So yeah, what's your thinking there?
Okay, so regarding overdiagnosis, it totally depends who you're talking to and which country they mean. So I'm absolutely convinced that ADHD is overdiagnosed in the United States. I'm equally convinced that ADHD is underdiagnosed in the United Kingdom. And the rates at which we are diagnosing in different countries vary massively. And that isn't just because, well, I mean, our populations might vary slightly. If you think that people in the States are perhaps have more immigrant background, and that might explain that they have a slightly higher propensity to ADHD, but it certainly doesn't explain why they're being diagnosed at 3 or 4 times the rate, and even more. And in terms of medication, I think it makes a huge difference how old you are. Because children, especially primary school and early secondary school, don't have a choice. They get told what they need to do, which subjects they're taking. They don't have any choice whatsoever. They must fit in with what everybody else does. And for them, if it's something which they find boring, it's really hard to sit still. Then the older you get, the more choice you have. So you can choose subjects later in secondary school. And then in terms of your future plans, you might choose something which suits you better if you have ADHD, which works for your strengths. And I think that is why many adults with ADHD who are high functioning don't actually need medication, and certainly not every day. Many people I speak to say they they use ADHD medication if there's things they must do which are really boring. It's things they find interesting, they don't need it.
Interesting. Right, yeah. Admin or whatever. You're giving me flashbacks to my own childhood. I mean, if I was in the US, I probably am in the top 5 or 10% or whatever. And just it's incredibly boring sitting through geography and history and whatever. But the UK system is really good at giving you the ability to specialize quite early when you're 15, 16, and then 18 again. And at university, we can do one subject alone, which is amazing. Whereas in the US, they still have to do like loads of other general studies. They have majors and minors, and I would hate that. Yeah, I definitely prefer the single thing and being interested in it, and otherwise we'll just be rocking my chair or doodling or whatever. Um, but we're here for my diagnosis, Annie. Can you give me a diagnosis? No. So okay, yeah. So this is a very interesting and kind of nuanced perspective, and I think maybe a lot of the people with ADHD, a lot of adults, they have. They recognize that they don't actually need the meds, as you say, and they can use them as and when they want. Do you kind of disagree with this perspective that they should be on them all the time, every day? I mean, sometimes I see, yeah,
Well, it depends. It depends which medication. So stimulants, which are the first line medication, and don't have to be taken every day because they work immediately and they work for a set number of hours and then they stop working. So those can be used as and when it's needed. And I never recommend that people use stimulants every day because I think it's really important to have a break. It's also important in terms of tolerance, and it works better if you sometimes have breaks, that the body resets in between. Non stimulants, you have to take every day, and they then work 24/7. And for some children, those are really helpful. So I work with children with intellectual disability, and many of them have ADHD. And for them, it's really difficult to understand a stimulant, the effect it has. They don't know why they're feeling different and why it wears off. And they need 24-hour control. So that's why non-stimulants, where you take it every day, is really helpful in some situations.
Hmm. Interesting. This is a very, yeah, very nuanced view that I don't hear when I listen to the American psychiatrists presenting on the ADHD, which is like a lot of my research is just listening to lectures given to like grand rounds or whatever by American psychiatrists, and they're very pushing you to like, no, as soon as you have the diagnosis, every person has to do it all the time because it's like saving your life from car accidents. And they had some weird arguments there, but I think yeah.
I'm always careful with those kind of things because you never know. Um, and it's sponsored by the drug. Yes. And the other thing you need to know about American psychiatrists is they don't have the same therapy training we do. So psychiatrists there are much more medical and pharmaceutically at- attuned than we are because we in our training do a lot of therapy.
Interesting. And so we were both here in Cambridge at this session where we had actors pretending to have ADHD diagnoses, and we had trainee psychiatrist. Well, actually, the exact case was a woman who had a child with ADHD, and she was coming to the psychiatrist and saying, "Oh, what do I do about this?" And the trainees were kind of given this task to try and give an evolutionary explanation to the lady, who it turned out in the end did actually have a child with ADHD in real life. It wasn't just acting. She was, and she found it really interesting. And I was sitting and watching her at one point. I was like, wow, she's a great actor. she's really like asking the kind of questions you'd expect from a person who's asking about their child with ADHD. And yeah, no, so she said it was, yeah, very enlightening, and kind of it reframed the symptoms and made her more optimistic about her son. Um, so yeah, when and where and how and what's the impact of ever using these explanations? Do you always throw them in, or do you sometimes throw them in when people really want to know why, or they need hope, or I don't know? Yeah, what's your experience, or do you just keep it as your own like knowledge?
I, I, I have a rule in my practice in that I want people to walk out of my office feeling better than they felt coming in. Uh, And that is something I always think about. How can I help people feel better after seeing me than they did before they saw me? And with ADHD, yes, absolutely. It's about giving people hope. With children, it's giving them hope because they feel there's something wrong with them. And I may not necessarily talk about evolution or anti-Galgaras, use those terms at all. I might just say something like, you have lots of strengths. You've got loads of energy. You don't easily get tired. You could think of lots of different things. And those are really important strengths. The only problem is that schools don't like that because they want you to sit still and they want you to listen to what they have to say. So what can we do to lessen the mismatch, basically, the improve the goodness of it is what I'm thinking in my mind. And then when I'm speaking to parents, often parents despair because they don't know that things become a lot easier as people grow older for many people because once you can choose and you can pick your environment to better suit you, and the goodness of it is better and people can thrive and flourish. So just pointing that out can be really helpful for parents. And also just things like famous people with ADHD. There are so many famous people with ADHD in all walks of life. That is also very important. So I always have the evolutionary perspective in my mind, but I don't necessarily spell it out in every consultation.
Right. Yeah, interesting. I'm also reminded of the sort of autism trajectory as well, because, a lot of kids with autism do just kind of learn to socialize more and fit in better as they grow up. But like, if you read the the the, the Cliff Notes or the Mayo Clinic stuff, it's like it's a lifelong neurodevelopmental disorder with pervasive difficulties which persist, blah blah blah. But actually, a lot of kids do get much better and or function more normally, but there's like that initial kind of grief of a parent who's like, oh my God, is this gonna what? Yeah.
Yes, that's because many people conflate autism and learning disability. So I think in the general public, people don't realize that there's a difference and that you can have high functioning autism, which can really give people the strength to pursue their special interest to a depth which it enables them to excel and which neurotypical people can't do. So I do agree with you. I think it's a cheat to call ADHD and ASD disorders if these people can, in so many respects, outperform neurotypical.
Right. And so the cool thing and the reason that I called this podcast, I asked to interview you now, is because you've just published a paper in collaboration with colleagues in Ireland, where you gave a presentation to the Irish College of Psychiatrists. Was it their annual meeting? Was it their kind of yeah, okay. So you went to the Irish college annual meeting. You gave this presentation on the exploration of ADHD from an evolutionary perspective, and then afterwards, you asked attending psychiatrists about what they thought, what their perspective was, which is super cool. It's very similar to the paper that me and Tom have been working on anxiety around the UK, which is slightly bigger and different in many ways. But you ask basically the same questions, and it's the same idea of exposing people, especially clinicians, to evolutionary explanations and seeing how they react. Um, and yeah, some of your results are just really, really impressive. I mean, so of the 10 questions that you asked, one of them was following this presentation. They were asked whether they would agree with the statement. Following this presentation, I'm now more optimistic about helping people with ADHD reaching a good quality of life. Um, so this was a 5-point Likert scale. So strongly agree. 61.9% of people said they strongly agreed that following the presentation, they were more optimistic about the outcomes for ADHD people and whether they could reach a good quality of life, which is like a ridiculous. Okay, it was only 40 people, which is actually not a bad number, but literally zero people said disagree. And then 60% said strongly agree, 38% said agree, and then there was the kind of remaining. So yeah, it was very impressive. And then, I mean, also just across the questions that you asked about whether this information would be useful for patients and psychiatrists, like again, almost everyone agreed and strongly agreed that both patients and psychiatrists would benefit. Um, if the information was known, would people be willing to seek help? Yeah, again, moderately or like strongly agree, and neither agree. Changed how people. This teaching session has changed how I think about patients presenting with ADHD. Again, like most people were saying yes. So a lot of people said they'd consider relaying this information to patients. So yeah, anyway, it's a super cool study, and it's definitely we need to follow up and like do it, bigger and better and more rigorously, and see how it affects the patients as well. Of course, that's always the caveat one must say. But I'm up to applaud you and Gurjot and the group for running this. Yeah, I just want to get your perspective on, well, how did that presentation go? What do you think of these results? Is this aligning with kind of your previous experience? I know you've talked about ADHD a lot in these kind of contexts. Is this just, were you surprised, or were you like, no, that's exactly what I knew would happen? I don't know.
Well, first of all, it was Gurjot's idea to actually do a study from the presentation, and I'm really grateful to him for having done that and capturing all of this. Because, yes, it absolutely fits with my previous experience and since, where when I talk to people about evolution and the evolution perspective of ADHD and more generally, people are generally very enthusiastic and want to know more and say, why haven't we been taught this previously? And so I'm used to getting really good audience feedback afterwards. And people are really passionate and interested, just like I was when I heard about it the first time, because this is such a brilliant idea. So it's really lovely to see how receptive, especially the younger psychiatrists are. And I think we were talking earlier today in another meeting about how what we need is a critical mass of psychiatrists and psychiatry trainees to know about evolution and understand the benefits of it. And then I think there will be a paradigm shift, because then it will be included in the training, and that will and spread this kind of thinking throughout all of psychiatry, which I think will revolutionize the field, because it then provides that framework you need to actually go further than just having separate bunches of tick boxes.
Right. So, yeah, do you think it is often the trainees that react most positively? Is it just because they're younger and fresher and more open to new perspectives? Or I don't, yeah. I mean, that's my experience as well. But yeah, I don't know.
Yes, so probably. You know how when you I mean, that's the reason why I chose child and adolescent psychiatry, to be fair, because I found when I was working in older age psychiatry, people found it much more difficult to change, because in changing your mind, you then had to acknowledge that you had been wrong for a much longer time. Whereas in children, it's much easier to change their trajectory than for older people. So that's something I always try to keep in mind myself, to try and stay open minded.
Yeah, it's not normal. I do wonder this, when we're trying to talk to the sort of the consultant psychiatrists who've been in the field practicing for 20 years, and then you come along and you give a presentation on evolutionary perspectives. And then, yeah, it's like you can kind of see there's this decision tree that they have in front of them. Like, do they try and do all this research into this new thing about evolutionary biology and the theory, and like, what is that? How does evolution work? And then where's that even going to matter in their clinic? And like, oh, I've been doing okay. I seem to have been fine for 20 years. There's not going to be that. I don't exactly know how this would benefit my patients. I'm probably just going to ignore this and not bother to kind of look into it. Whereas the trainees have.
But that's why I'm looking forward to your book coming out, Adam, because I think if that can galvanize the general public to ask more questions of their psychiatrists, um, but
Yeah, I do want. Yeah, that's what I'm sort of hopeful for. I think that I see so much positive reception in the general audience and the people. Yeah, just normal people, and also the trainees. Often it's the people who've like spent decades kind of working in their own particular paradigm that are just more resistant and don't really see the benefit and can't be bothered. But yeah, some external pressure from their patients. Yeah, that's absolutely. I think um, one of the ways we can push the field forward for sure. So, what do you think? Like a trainee. I mean, you obviously had this perspective from kind of like fairly early on, but where do you think this would fit into the kind of trainee training? Like when do you want to start talking about evolutionary perspectives? It's interesting because, as you say, it's maybe not going to affect your clinical interaction too much, or like you occasionally weave it in, or but it just helps you as a clinician.
I think it affects the clinical practice dramatically, because it affects how the psychiatrist thinks. So, so it affects how we treat patients if we see them, for example, as caught within a mismatch between how we evolved and how the expectations of our modern environment, rather than seeing somebody as having pathology. It absolutely opens avenues for new thinking and new hope, which were not there before if you just see somebody as having a disorder. So even if we don't talk about it in the clinic, I think will still revolutionize how psychiatrists think. And if we do talk about it in the clinic, it can definitely reduce shame and blame for people who were told that there's something wrong with them, to then find out actually they just have different strengths and they need to really find their niche so that they can then accept.
Right. Yeah, I've heard this before from sort of more senior psychiatrists who have known about the field for decades and who said that it kind of, even though they didn't weave it in too much, it gave them kind of more enthusiasm for their job. It made them be like a bit less like, oh, your brain is broken and I don't know what's going on here, or you're manipulating me, or whatever, or like there's so many different things that can go through your mind, obviously, in dealing with a patient, which might create a barrier. And this is also often talked about by kind of repeat patients or people who've been in the system for a long time, is that they often feel like they're kind of othered, or they jump between psychiatrists and then they're never really seen. And yeah, it's a weird one because it's not like something. It's very hard to kind of formalize as a sort of intervention in a kind of classic sense, right? It's just more like giving psychiatrists this knowledge will help them be better psychiatrists, and that will improve patient outcomes. But it doesn't sound like a new therapy or a new pill which we can test rigorously in randomized controlled trials. I mean, I suppose we could test it by like training some psychiatrists and not others, and then seeing what their impact, or like if they just go about their practice, are they more effective? But
Yeah, but I think you could say the same of physiology, for example. No, I don't think any doctors, let's say GPs, talk to their patients exactly about how physiology works, how exactly the lungs work, or the heart, or the liver. And but understanding that makes them much more able to diagnose and sensibly treat pathology. And that's the bit which is missing in psychiatry. And that is where the evolutionary perspective can give us that, so that we are not rudderless, that we can actually understand what we're doing and can find a way of moving forward to help more people. And that is something I hope I will still see in my lifetime. It certainly is, I'm certainly experiencing the beginnings of it.
well, and you've been a key part of it, Annie. So don't downplay your own role. And I'm absolutely optimistic that within your lifetime, so long as you have an average lifetime, I mean, fingers crossed. Then give us maybe 5 years. I reckon, give us 5, 10 years. I think we should have seen a real change. Um, yeah. Um, Okay, this has all been super. Do you have any final words for the clinicians and the psychiatrists out there, or anyone? Is there anything you'd like to say before we wrap up?
Give it a try. Read up about evolution. Look at the information which is already there on epsit.org. We have got lots of videos. And if you are registered with the Royal College of Psychiatrists, you can become a member of the Evolutionary Psychiatry Spot for Interest group just by ticking a box. If you aren't, if you're not a psychiatrist and you're interested in this stuff, you can still become a member, and by making contact with me or through Adam. And the more the merrier. We're trying to get the word out, so anyone who's interested and would like to join us is very welcome.
Yeah, and I do meet people very often, especially at the events, who are interested and who do listen to the podcast and have like learned something from that. So, yeah, it's great to have you on to talk a bit about ADHD. I would recommend everyone to, yeah, do a bit more reading and thinking about like what this means to them and to their patients, and even just weaving in this very simple explanation. I think the kind of joy of it is you don't actually need to be an expert in all of the depth of the theory. Like, it would be nice if you're going to write papers and publish on it, then maybe, but to become a clinician who's just informed and, understanding their patients a bit more and weaving in the odd, oh, well, it's not natural to be sitting in a classroom. You're going to have some strengths that will appear if you find the right niche. Those are things that you can do without having to be like an expert in the field. So I think that's one of the optimistic aspects of this field. So yes, thank you so much for coming on, Annie. It's been a pleasure. I look forward to seeing you at all the future events and, whatever, all of the EPSIG stuff that's going on.
Thank you so much for inviting me, Adam.
The Evolving Psychiatry podcast is financially supported by the Human Ecology Group of the Institute of Evolutionary Medicine at the University of Zurich.